Started. Good afternoon, everybody. Thanks for being here. I'm Dan Egan. I'm one of the board members at large, and I'm happy to have our mostly monthly Cord Connect session today, which is being led by Jeremy Branzetti and Laura Hopson. And so thanks for taking the time out of your day. And like all of these, this will be available in a recorded session afterwards, and our speakers are certainly willing to entertain questions throughout. So if you have questions, you want to put them in the chat, or at the end, can facilitate some questions as well. And so with that, I will turn it over to our speakers.
Wonderful. Thank you, Dan. Thank you, Cord, for allowing us to come and speak today. And thank you guys for attending. As Dan mentioned, we're going to talk about this concept of adaptive expertise. As I get my slides opened up to begin to walk us through, please, if anything comes up, throw a question in the chat on the side. If possible, while we're navigating the dynamics of talking, we'll try to answer it on the fly. And if not, we can have that all be queued up for the end for a discussion as we get to the end of our material. So with that, let me get this here. And all right. Can everybody see my slides okay? Excellent. All right. So let me get all of the pictures a little bit less on the side here. So adaptive expertise, that is what we'd like to come talk to you about today, and why we think that this is probably very implicitly, but worth making explicit, is how important it is, particularly for emergency medicine training, but physician training overall. With me, as Dan mentioned, is my longtime collaborator, Laura Hopson, and we're presenting content co-created with our other collaborators, Linda Regan from Hopkins and Mike Gisanti from Stanford. We've been talking about this topic now for a number of years. It's served as the source of thesis material for 3 out of 4 of us. So hopefully we can make it then useful and important and stimulate some great discussion about what should be some of the guiding points of emergency medicine training. So with that said, what I'd like to outline as my objectives here would be to discuss these concepts of routine and adaptive expertise. And we're going to frame that in the broader context of what the heck do we think an expert is to begin with. Once we've put these two concepts out there and have framed them, we're going to then develop the 4 developmental principles that we believe promote this concept of adaptive expertise. And then most importantly, what we really want to pride ourselves on doing, and hopefully you will do a good job of this, is to help you both evaluate your program for where it is or perhaps is not teaching this material, but also help you have very specific takeaways for that. So that's really what we want to focus on these deliverables. We're going to give you reflective questions. You can take them away. You're going to, like, after today, you can be with your program co-leaders and sit and think, oh, if we think this is important, are we doing it? And if so, or if not, here's where our current lay of the land is. And then after that, you can have specific instructional strategies that you can tap into to address whatever those deficiencies may come up. So let's hit this first objective, this routine and adaptive expertise. As I mentioned, this word expert, I think, is something that we all use quite commonly, but when you do that neurotic level of depth assessment into it, you start realizing, oh, well, what exactly does that mean? I mean, I could ask you guys a question, right? Are you guys experts? You are the emergency medicine provider. Most of you who are tuning to this are probably the attending when you're showing up. It's not showing up on shift, and therefore are seen as the boss. You are the expert person there. For simplification, a nice starter definition, though, we can think of for expert would be this sort of elite or peak performance at exceptionally high levels consistently on a particular task. So there's quality, there's a thing you're doing, and then there's consistency there. But keep looking at other thoughts of reputation. Is it of expertise? Is it reputation? Does the fact that I work at a large medical institution versus a small one bolster or hinder my reputation? Does my title do anything about that? Is what people just know of me, regardless of what I've actually accomplished, make a difference in what people think of me as an expert or not? The old Malcolm Gladwell pop culture concept. Is it just the number of hours you toil away as you build up an area of knowledge? And a lot of this actually has been debunked, in at least it's been clarified that there has to be a deliberate element to really this time spent. You can't just keep redoing it mindlessly. But let's keep in mind, the American medical education system still uses this time-based approach. There is obviously talk about different ways of approaching this, but we still do have this assumption that enough time will equal expertise in a topic. But what's actually started coming up is CBME. We heard about this, if those who were able to make it to the keynote, this discussion of CBME as the expectation, this competency-based medical education. We now show the work that we do and have our learners demonstrate that they are good enough. But is good enough the same as an expert? Is that enough? As a bit of a skeptic, I would argue, no, that's CBME is the lowest bar that we set for everyone. Not that the bar itself is low, but it just get over that bar. But what about higher and beyond? How about the growth that can happen in expertise that can come out of that? All this really amounts to is there's not a really clear conceptualization of this in the way that we approach training. Expertise, there's some sort of secret sauce. There's something that gets people from good enough of competent to expert. And I think what I would like to, Laura and I would proffer today is that this concept of adaptability may be that thing. And I think there's some really important items that we can take away from that that would argue in favor of this. So if we look at this adaptive and versus routine, here are the two kind of bold categories we're going to look at. On one end is routine expertise, efficient performance, master task, high level, and in typically familiar situations. That's kind of that same expertise definition I gave a little earlier on. But you can see some key points here. The consistency, high level, and it's a thing that you know how to do. You've been trained to do this thing, and you're now doing it regularly and reliably. But what happens when the task varies? If I'm a widget maker and somebody says, change the widget, do I know how to deal with that? If I'm working in an ED and I'm used to seeing a certain type of patient who complains of chest pain and now it's an entirely different one, do I know what to do with that? What if the clinical environment changes? What if there is either more busyness or different population of patients that come in or different disease presentations if I'm in a developed versus non-developed country? Or what happens when things just don't go according to plan? All right, we are ER providers. We all have our war stories about this. And so you know that there is absolutely times when you've been like, uh-oh, I haven't seen that before. And what do you do then? And we would say that this is what's really covered by adaptive expertise. Adaptive expertise is this idea that you can take existing knowledge, you can learn the important pieces, what we call abstract. You would take the key parts of what I've learned before, make a new solution, and apply it to that unknown problem. I mean, even at its simplest level, behind me, there's a door. That door has a handle. No one's ever actually taught me how to open this door, but I know because I've gone through hundreds, if not thousands of doors, I know that there's a thing that will turn that will disengage a door and let me go through it. So the handle can look different. It could be push, it could be pull, it could be all these things, but I'm abstracting knowledge about how these things work and applying it to the one I'm at. And that's a real simplified example, but the concept still upholds. And if you really then take it to the next level in emergency medicine, there's a lot of ways that could apply. But fundamentally, the person who can do both complementary skill sets, routine, I've mastered things, I see them, the pattern, I do them really quickly, and I do them well at a high level, and the adaptive expert who can innovate is the thing that we're trying to build. The routine person knows how to kick butt in these situations they've seen before, and the adaptive expert knows how to be creative, apply these solutions in unfamiliar circumstances, and still get the right answer, even though they haven't practiced or trained at it time and time again. And the person can switch between the two. Not only are both skill sets capable or within them, but they recognize the need for both of them and can swiftly and frankly, without conscious thought, adapt as to when I need to do one or the other. So with that said, I'm going to turn over to Dr. Hopson to take for the next objective.
Hi, good afternoon. And I am maybe displaying my adaptability, albeit maybe limited expertise in technology this afternoon. So if I suddenly vanish or have transmission problems, please bear with me. So our second objective is to think about what the developmental principles are that we can lean into that can facilitate the growth of adaptive expertise in our learners, our colleagues, and potentially even ourselves. And this matters because we're in a constant state of evolution. If you want to think about emergency medicine on the global scale, we have new discoveries, our medical knowledge is expanding, we're developing new treatment approaches, new technologies, and certainly, as we discovered 4 years ago in a rather dramatic fashion, we have novel disorders that present to the emergency department and dramatically change how we interface with our environment. And even as Jeremy was talking about on the day-to-day time, our patients vary, our resources may vary unexpectedly, our IT systems may function or not function, and we need the ability to work within these changes. So what we do know is that studies of diagnostic failure say that reliance on rote performance is really insufficient, and that physicians need to be able to identify where gaps in their expertise exist and develop strategies based on certain underlying principles to address those gaps and plan their practice. So when we start thinking about these principles, Jeremy, if you'll hit the next slide, we are really working within these to develop the type of physicians that we want to be. So key foundation one is that conceptual knowledge still matters. While we may talk about, hey, we don't need to have, knowledge is easily accessible, we don't need to have everything in our brain because it may be so accessible on our phone or up to date or Wikiem or whatever resource we want. There's nuance to that, right? We need our learners to really have a deep mechanistic foundational understanding of the problem or topic. It doesn't mean that they have to have every detail, but they have to have a conceptual framework that they can work from and take this knowledge so that they can abstract from it to the setting that they're in. How do they transfer this knowledge to a new environment? And what does this look like? So we're all drilled around anaphylaxis. It's epi, epi, and epi. Well, what happens when you get a 75-year-old who's known to anaphylax with bee stings, who's having a perfectly lovely spring morning and encounters a nest of yellow jackets? He comes in with anaphylaxis. Well, you give him epi and his anaphylaxis symptoms go away, but his ST segments go up. And guess what? 45 minutes later, his anaphylaxis symptoms, diffuse hives, maybe a little bit of stridor and wheezing are coming back. His ST segments have gone down. What do? How do you parse this problem? How do you help your learners work through this? Some of this is going to really lean in on cognitive apprenticeship principles, getting people to think aloud, discuss mechanisms, discuss approaches. If we know we need to be activating the cellular cyclic AMP, is there another way that we can go about this that maybe protects this gentleman's cardiac status while addressing the fact that something else is going to kill them? So leaning into this idea that we still need conceptual knowledge, we need those cognitive frameworks, those schema to be able to approach problems that have novel twists to them. We can also think about this in terms of how our conceptual knowledge needs to interface with with protocol. You have a 26-year-old who presents with a migraine, comes in and says, I have a migraine, I just can't get it under control. Your trainee staffs it with you as I'm giving them a migraine cocktail. Do they truly understand what this means? What role does the Benadryl play, if any? Can you take it out? How do you vary this if someone has an allergy or an intolerance to medication? What's acceptable? Why can or can't we substitute Zofran, ondansetron for the major tranquilizers like metoclopramide or prochlorpromazine that actually do have efficacy? So being willing to engage on those questions with that evoke an understanding of the how and why is also how we can promote these conceptual frameworks. Another element that really the literature supports as developing this type of adaptability and expertise is meaningful variation. And by seeing examples of clinical presentations with subtle differences, a learner can really help build their own cognitive framework or heuristics or conceptual knowledge around what holds all of these together. What are the underpinnings? And this involves not just the exposure, but really actively thinking and reflecting on how these presentations are different, how they require different approaches, different management, and yet how do they have overlapping similarities that can be applied to different cases. So how does fever differ in an elderly patient, a normal 30-year-old, if you will, with no underlying comorbidities, a 2-year-old, a 6-year-old, a 2-month-old, a 2-day-old? All of these are critically important to understand and lean toward this goal. So how can we build this intentionally into our work on the one-on-one basis, whether it be with ourselves or with our learners? And some of this involves intentionally thinking about how we're discussing these. Can we do things like build in intentional comparisons when we're in the middle of staffing? It may not take very long, but how would you change this, your management decisions, if you did or didn't have this resource? Is something that I will often have or a discussion I will often have with my learners, since we have them working at ridiculously well-resourced quaternary facilities, a well-resourced community hospital, and a county hospital, and many of them have an interest in low-resource medicine. So how can we lean into those interests and different capabilities to say, these are all variations on the same thing. How do we change based on our resources, based on our patient presentation, and make intentional changes? And all of these really lie into a hypothetical questioning approach. What if? How do we change this? How do we vary this? How does this change our approach? That may not take very long and doesn't take a lot of resources, but really can help build learner facility with this idea of variation. And another key domain which we can lean into this idea of variation, in which there may be more time, is that of simulation. Here's an opportunity to create variation where you may not have experience within the clinical environment. There's some data that says our learners will only experience roughly 40% of all the patient presentations that they really need to be facile with by the time of residency graduation. So we know simulation can fill that gap. And it also provides not only a chance for those opportunities, but a chance to temporarily stack those so that you can see a presentation of an aortic dissection in the simulation environment and maybe compare it intentionally to what a right-sided infarct would look like, maybe compare it to what RV failure might look like in the setting of a PE. All presentations of chest pain, all emergent presentations of chest pain, all of which may be very different, that we can lean into the simulation environment for learning with. Another element of developing adaptive expertise within our learners is really allowing the chance for productive struggle and discovery. And this is actively recalling, abstracting their knowledge and applying it to those situations that it occurs. If we think back to the simple learner model of the 1-minute preceptor, it boils down to, what do you think is going on? We're asking them to activate their own knowledge and provide a conclusion and a justification for it. That's leaning into this whole concept of productive discovery. So we are allowing our learners to struggle and fail with a problem, but it has to be done in a safe manner, both for our learners as well as for our patients. We certainly can't allow harm to come to our patients that we're responsible for. And we also cannot allow our learners to be harmed by making a mistake or a conclusion that isn't accurate. There has to be allow for discussion and exploration environment, and not a penalty when someone doesn't have the right answer. It's a learning opportunity, whatever we think of how overused that phrase may be. So what we see coming out of this is we're building people's problem skills. We're building the problem-solving skills, we're building the ability to be resilient and our thinking. And this active engagement is what is going to allow our learners to really develop long-term personal learning skills. So how do we do this? Thinking about what is appropriate learner autonomy in the clinical environment. Is this something that there is more than one acceptable manner of solving? And if plan A may be your preference, but plan A is reasonable with an equivalent outcome, let's explore that. Let's let the learner engage with that. And let's think about how do we ask questions that may evoke this process in our learners. So your patient has this condition. They don't have the ability to access outpatient care. How do we modify our plan? Let's actively think about all these processes. And our final core developmental principles that we want people to learn into in the development of adaptive expertise really is the need for our learners to have self-regulated learning skills. And what we heard over and over again as we were exploring this in a variety of studies is that our learners, even those who don't seem to be very successful at this, really lack formal training in how to go about learning. And this learning may be identifying their own needs, setting goals, self-assessing their learning processes, and actually implementing some of those evidence-based processes that are shown to be effective in optimizing learning effectiveness. And we need to tell no one that we are working in an environment in which structures progressively disappear. So we see people moving from those preclinical years in medical school where there's a class with learning objectives and tests and a final exam and a grade to the wards with their rotations, where you are told to go and be successful and learn. And maybe you have a shelf exam and maybe you have some more accountability, but there's your learning is now guided much more by the vicariousness of patient presentations and much more guided by opportunism in a good sense of that word. And then as we move into the GME space, everything really becomes guided by the clinical environment, so that people need to have good structures underlying this in order to really effectively support their learning. So how could we lean into this? We may want to think about, do we develop a learning how to learn curriculum? Maybe this is something that deploys in intern orientation and then is brought back periodically throughout someone's residency training. Do we learn into the whole idea of self-generated individualized development plans or individual learning plans, obviously with reviews and accountability, and using these as another training mechanism to help our learners generate their own skills for when they're completely out of any type of structure and in independent practice. And then again, leaning into things like coaching, where they're with a non-judgmental guiding approach to help learners develop the skills to reflect and integrate all of this potentially overwhelming senses of information.
So now that Laura's laid out the four principles, we now kind of have the foundational basis to say, what are we all doing in our respective programs and curricula to be able to teach to, I should say, the level of adaptive expertise. So I want to be able to help now with delivering this more practical minded part. Before we dive into that, let's sort of do a little bit of reflexivity, I guess, to use a qualitative researcher word here. There is yet to be a proven adaptive expertise course or curriculum in medicine. So the things that we're going to recommend are as best as we can recommend based on literature, based on our empiric data, based on our collective expertise in this domain. But this is something that's probably going to evolve over time, and there may be more ways, certainly, than what we're going to recommend. But hopefully, for you all, now that you are gathering a conceptual knowledge of adaptive expertise, you can start thinking of other ways that may be applicable to your program as we go through them. By using those guiding concepts, you can then look at your curriculum and figure out where your opportunities are for improvement. And then really, I want to challenge you to say, how is your assessment system functioning? Is it demonstrating competency alone? Or is it actually helping to encourage or define or prompt adaptive expertise? I'll say one of the more fascinating things that Laura and myself and our team have found repeatedly is every study we do with residents, we've yet to find a resident who says, what's been really helpful? That resident eval system. That's really taught me a lot. So it's a real interesting question of what we're actually accomplishing through our standardization approach of evaluations. And I think it means there's an opportunity for us to rethink how that's used to prompt adaptive or other types of learning. So with that said, This giant chart, don't bother looking at the content here. I'm putting this here to show that there's a one-stop takeaway that in a paper we have, I'll pause here as I speak, or at least speak to draw out a little time. You can go via this link straight to it from AEMET, and it will have the content of much of this talk, but in particular, each of the reflective questions that I'm about to pose to you, and further information about the specific curricular interventions that you can go undertake. So with that said, let's dive on in. That first developmental concept, conceptual knowledge, the idea of truly understanding a thing rather than just memorizing it. Asking yourself, of course, what are we emphasizing? Are we teaching understanding? I get the core concept, or are we teaching sponge up the material and squeeze it out onto a test, and therefore we've demonstrated knowledge? But those are two very different things. The person who just sponged out their knowledge onto a test, test them again in a week and go see how they perform. It's not going to be pretty. Think back on all the times in medical school. I'm sure you all have similar memories of that. Just as importantly, are you using your curriculum to help learners connect the dots? Delivering information can be done through the internet, through textbooks, through podcasts, through any number of formats, in addition to your resident learning experiences or your formal conference. I would argue, and I think Laura would probably agree, the conference benefit is when you have everybody together, you can start doing these comparisons, these showing things side by side. How do they interrelate to each other so that you're helping people draw connections? You're drawing upon the wisdom of the crowd, more so than just saying, this is the 6 killer forms of chest pain and repeating them, where anybody can get that anywhere. So then are you pushing them to build their scaffolds, their own scripts, their own schemas and thought processes? Are they starting to think of their own rules, how they approach a patient? Have you ever asked them, hey, what's your approach, your key things you're going to ask about this? And then how do you know if they actually have this conceptual knowledge versus the memorization? As I said, the medical education system really has taught us to be memorizers. It hasn't necessarily taught us to be knowers. And that difference makes it that fact that that's there is hard to be able to show the difference of, because most of our testing really gets at the memorization side. So for curricular interventions, some simple things. Some of these are more conceptual than a definitive curriculum, so I'll acknowledge that. One is when you're writing something, when you're teaching something, whatever that may be, the thinking of I'm trying to address why of this thing, not what is the thing or what is the right answer. Why is the choice of medicines for migraine important rather than what are the ones that we just click off on a EMR ordering set? Particularly UME has the setup of multiple forms of assessment and classes. So there is a lot of short-term learning that is done. The test is done and then it's pushed out of our minds and we move on. As you get to GME, you're starting to get to this point where people realize I need to maintain a body of knowledge through my whole career. So this focus on long-term, what makes things stick? So those evidence-based learning principles like adaptation and repetition and elaboration and so on and so forth really become relevant. And how are you including them in your curriculum? The ITE is an important marker of medical knowledge, for sure. It is reliable and valid for knowledge, but not necessarily how the knowledge is applied. Not how it's integrated, not necessarily for how do I take what I know here and change it in the moment. It doesn't do many things. And we are trying to implore you to do is not see that as the end all be all of what someone knows, because there's so much more than just the quote unquote medical knowledge versus conceptual knowledge versus the ability to integrate or apply things. They're very different. So use it. It's helpful. I certainly don't want a class full of people who fail the IT because they're probably going to fail their boards. And that means they probably do lack medical knowledge, but it's not enough. So maybe necessary, but not sufficient. And then especially when you're in small groups or sim, make your learner externalize their thought. What are you thinking here? Okay, pause. Tell me what was going through your mind. And not in the pejorative, like, what the hell were you thinking? But like, oh, that's interesting. Tell me what was going on right there. And conversely, as you're teaching, do the same thing. If you're doing a procedure, instead of just, okay, I have prepped the patient for a central line, I have now anesthetized the skin, I have done these things. Why am I doing this? Why am I doing this part? What is my thinking now? What am I preparing for down the road? Will really help open the minds of your learners by shedding a light on what's going on in your mind, the expert mind, as they're building their expertise. So shifting over to this meaningful variation concept. questions to consider would include what learner tasks or roles or skills in your program do not have intrinsic variability, and you should build them in. I worked at a institution in the Pacific Northwest where there was a lot of IV access difficulty in the population due to a lot of injection drug use. I never really had to teach my residents how to do IVs or how to get access on people because it was so ubiquitous in the curriculum and so many variable instances of it, they were going to be good at it. So it's a waste of time to spend on that in that curriculum, ultrasound guided lines, extra teaching there because they were going to do it. But other disease processes they may not have seen. If I'm practicing on a military base and I'm mostly seeing young, healthy men, mostly, obviously it is more diverse than that now, but young, healthy people will say with chest pain, that's a very different disease process than surrounded by nursing homes or in a place with an uncontrolled population with uncontrolled diabetes, hypertension, smoking, etc. So where does your curriculum have variation and where it doesn't? Consider what you need to do about that or what you can supplement. How are they cultivating self-reflective skills? This will come up in particular for the later task of self-regulation, but variation is helpful, but I want to be clear, it's not just building a bigger script, right? I'm not just putting more branches on the little tree algorithm in my brain. What I'm really doing is giving opportunity to compare and contrast and learn rules or learn lessons to take away that difference provides me. That's the real key takeaway here. So to that end, what are these higher level connections that you can find in cases and help show that to learners that may be not coming through in your program's teaching? Laura talked about this idea of hypothetical questioning. She also talked about how there's a tension, right? You want to provide variability and give people the chance to do their own thing or to try new things, but we're doing high stakes things with real patient lives, right? So there's a balance here, how much we can vary here just for education's sake. But using these questions hypothetically is a safe alternative that threads the needle, much like, frankly, simulation does. You can create so much variability through either cognitive questioning or a simulated task that is safe but challenging and really stimulate these opportunities in your learners. It really kind of makes an argument for a much more broader use of time for simulation or variable task training rather than simple content delivery in your didactics. Another tenet that was discussed was this struggle and discovery, but really important is that word productive. So what is the learning culture of your program? Is it an embrace of when I don't know something, then darn it, I'm going to try to learn, but it's also okay to acknowledge when I don't learn? Or is it more like the actual medical culture in most places, which is performative? It's I only want to show when I know something, and I'm going to hide when I don't. That kind of culture is going to run headlong into adaptability and learning and embracing success from failure. And that's a hard look in the mirror for most places because we're a part of a broader culture than just our program. But it really matters all the little ways. Do you just reward people for the right answer? Or do you reward them for sharing when they got something wrong and what they learned from it? Two very different approaches, but that cultural difference really weighs on this part. Are they, to the point I was making, are they rewarded for the right answer or are they rewarded for learning the right answer? It's a subtle difference. And yes, you certainly want to not ignore people who have put that work in to understand the knowledge base and get answers correct. But it's the work in progress, it's the learning, it's the upward trajectory that you really want to be able to support. And so are you equally supporting those learners or calling them out for positive purposes, I should say? And then to your own way, it's how do you balance that? We care for real life humans, and we have learners that we have to be careful about how much failure they can tolerate in a stressful environment before before the learning gives out to just despair. To the other end, how can I construct an environment that allows them to try things, to experiment, to even screw up, but then learn importantly from those screw ups? So from an intervention standpoint, I think one of the first things is we've seen time and time again, there's a giant gap between UME and GME, and bridging that gap by at least knowledge, at least letting them know, hey, you're about to be in a world where no one's going to be over your shoulder nearly as much. You're going to have to figure out what your learning gaps are versus your classmates' gaps are. And you're not going to get the same level of like praise and quizzes and tests that seem to let you know you're doing well. That unstructured nature where they're going to have to figure out what they need to know is a big shock to the system of many learners in GMA. Use orientation as a chance to make them innovate. Put them through an ACLS code before you actually teach them the ACLS algorithm. they're going to do terrible at it, but they're going to figure thinking out. They're going to piece together prior knowledge. They're going to then learn really, really important sticky lessons in their brain about, oh, that's where that went wrong. I'm never going to do that again. Whereas if you just teach them this algorithm, then they open the algorithm in front of the mannequin and then they go down it, they're learning to use that thing, but that's all they're learning to do. They're not really learning why these things work and what to do if, God forbid, something goes wrong, their phone's not on, the paper's not there, whatever. Laura alluded to this before. This give as much autonomy as is appropriate to the level and skill set. Dan Schumacher called this relational autonomy in a paper once. And the idea is, right, you give 4s or 3s in your program, depending on what training format you are, more leeway than interns, duh. But you scale that to the patient, to their skill, to the learner's skill set, and you give them that ability to choose a different path than what you might have done, as long as it's safe and reasonable. Yes, you have your patterns, and yes, you have your ways of doing, and yes, you are the person in charge. So it always comes down to the safety that comes from that. But even for yourself, for your own learning, perhaps the learner is on to something new that you're not used to. And if it seems reasonable and safe, try it. And that may give you both opportunity to learn and be better providers. Laura already elaborated on the importance of commitment. Learners putting skin in the game and saying a thing is critical. If we've all watched Jeopardy before, you're sitting there and you're thinking, and they say the answer or they say the question in your head, like, yeah, I know that answer. And then the contestant says it, like, yeah, I knew it. It's very different than if you force yourself to say it out loud, especially in front of other people. You start noticing your knowledge base perhaps isn't as strong as you thought. So that commitment puts it on the record and makes somebody confront their true level of knowledge, not their idealized level of knowledge. And then guided discovery. That's that idea of doing the thing and practicing and failing or experimenting before you learn to do it. So do the sim of a skill thing and then come back and teach about aspirin overdose, or teach about TCA overdose, or teach about massive PE, whatever that is. Go through the clinical experience and then, or the managed experience, make them solve problems, make them figure out something on the fly, even if they fail, and then come back and teach the principles that'll stick on their mind about their experience. And so finally, let's turn to this self-regulated learning idea. This is the point that learners, as we get particularly into the practicing spaces, attendings, no one's going to tell us what to know anymore. No one's going to tell us what to learn. You do your board certification re-updates, but that's it. It's very different from the early parts of school and training. So people have to take this on themselves. So to your, as program leaders, how do you know that your learners know how to learn? As Laura and I said, we've looked at this in a couple different studies, and most of them really don't. Some of them have figured it out. Some of them have had previous lives that have taught them to do this. But frankly, it's a minority, and it's a pretty small minority. So I would argue then it really should be starting in UME, but in GME programs, it's incumbent upon us to at least make them aware of this and at least show them methods that are more effective or efficacious in their learning. Do you prepare self-directedness? Do you tell learners, hey, it's on you to set goals? Oh, you didn't set goals? Okay, then that's going to be your loss for your learning over time. Do you empower them, perhaps is a better way to say that, and make them accountable to themselves to be able to understand their self-directedness? And then can they practice it? Do you make them set those goals at semi-annual evals? Perhaps on or after shift, is there declared learning goals? Is there ways where you are inquiring with them and giving them opportunities to practice these skills that they don't do well at? So at the same time, I think many programs do try to practice this, but sometimes abandon them because the learners, reject it, or they're shy, or they don't want to look dumb. The persistence really matters because it gives them a chance to practice and actually get good at a thing that they're starting very terribly at. So what can you do in your curriculum? So Laura talked about both of these before. One is we actually do this in our orientations. We talk about evidence-based learning. What are the things that you can do that are effective learning techniques that science says works better than what they've just been doing forever? Do you have a coaching program? This is taking on more and more popularity in the learner space. So more programs here probably already have some similar program to this. But the idea here is not the coach is responsible for making sure they complete EPAs or milestones. It's not doing semi-annuals. It's, hey man, how's your learning going? Oh, you had this really interesting case. Tell me about it. What did you learn from that case? Is there anything you want to do differently? These coach-like questions to really prompt in them the internal drive to be better doctors, rather than just say, this is a hoop to jump through, check off these boxes, because that's not where expertise will come from. And then the challenge to all of you as the clinical providers is, what are you role modeling in terms of learning in your practice? Do you acknowledge when you don't know something? Do you say, I'm going to look it up? Do you announce when, I was wrong about that? Do you share that vulnerability and demonstrate that even practicing physicians don't always know the answer, but at the same time show them, but you're darn well sure I'm going to, and I'm going to find that out to a standard that I expect of myself, and therefore an standard you expect of them. So we're reaching the end here, and we can take some questions in a moment, but we do believe, I should say, adaptive expertise is functionally the real outcome of what we want of emergency medicine training. You can further define that in terms of procedural competency, clinical competency, communication, et cetera. There's all these things that are there. It's obviously not just this one simplified statement, but the person who can do many high-level tasks effectively, efficiently, quickly with high performance skills, but also recognize when things don't fit the pattern, when they don't have the full knowledge. This is a novel concept where they need to do some real deep thinking about this to be able to figure out the right answer, and to switch effortlessly between those two mindsets. We find that adaptive expertise has 4 core developmental principles. This is still an area of research that I think more data will come out over time, but I think these are 4 great concepts to think of as you build your curricula. And then to that exact point, these are not things that are expressly taught in traditional residency curricula. I'm willing to bet educators, people who are willing to show up to a session like this, probably do things like what-if questioning, probably are simulation leaders who realize the beauty of simulation for being able to make these tough environments where people can learn and struggle at the boundary of their knowledge. But it's not everyone, and it's not the entirety of our programs. I'm confident about that where I practice here. Therefore, we have to be conscientious and expressly teach these principles, or teach curricula that foster these principles. We also, just as a last piece of takeaway, put together about a year ago this academic medicine last page about the idea of adaptive expertise. It will cover a lot of what we just spoke of. Frankly, this talk is a combination of this paper as well as an AEMAT paper that I showed earlier. We hope both are useful resources. We have one-page takeaways in each of them for the busy practitioner or the busy program leader about what you can do in your program to improve the curricular environment for adaptive expertise. So with that, we are done here. I'll stop. I'll thank you for your time and attention, and we're happy to take any questions if you have.
I'll ask one if nobody else has one.
You're up, Dan.
So as I was listening, and then you kind of got to it, so I'm just curious to hear your thoughts. So, we've heard for a while this idea that every resident should have an individualized learning plan. And kind of, I think that's somewhat in line with this idea of learning coaches, which I actually love. I also, thinking from the logistical side of program leadership, imagine the resource intensity of that process. I don't know if there's data on this or anything. Is there value in having almost like small group learning coaching sessions, because you want to protect the vulnerability of people to have open conversations about that. But I imagine if you got 4 or 5 people together, and did that with some frequency, a little easier on all the APDs and the PDs and things to kind of have some of these learner-directed conversations. Do you think that would be effective, or do you think this really is something that is much more individualized or needs to be individualized?
Laura, do you have any thoughts on that before I chime in?
Yeah, I think the answer is, and I suspect this is the answer you're going to give, but I am more than also interested to hear your thoughts, because it's a great question, is the pragmatic components of implementation. I suspect the answer is nuanced, that you may be able to get some of this out of a small group setting, but there may be elements, particularly if you have someone who's struggling or feels as though they don't quite fit the mode of some of other people in their group, who may require additional one-on-one intervention, or may have, or a protected space in which to have a discussion about what to them feel like are deeply personal issues.
Yeah, I mean, I guess in my mind, I was thinking we do the individualized thing for the struggler or the person struggling, right? Like we have that set up. We've got a specific APD for that, but I'm thinking about maybe the person or the people that aren't necessarily on the radar as struggling, but would obviously benefit from this kind of conversation or intervention.
I don't think that there's a ton of certainly like evidence-based data that I could say this is the right answer. But I will say, one, from the coaching world, group coaching is definitely a thing that's considered to be a useful middle ground for when there's limited resources. Two, with a group like that, if you are able to engender a group sense of safety where everybody feels like we're here together to talk about this, rather than the common feeling residents have about any of these things, which is it's a hoop to jump through, who's assessing me, what's my score, what are people, like these things. If you can avoid that in the discussion, because perhaps it's led by a PGY4, right? What a great way to teach, or PGY3, again, in whatever your program is, what a great way to start empowering the seniors to have a meaningful role of shepherding the juniors and through this thought process. That could be great. I was talking to also to another colleague. We sort of have this interest in, how do you really make the most out of failure? And, he was talking about starting an orientation and just giving interns a bunch of failure cards, which is like, you're going to do all these screw ups, and you can turn them in when they happen. Like, and, part of it was like, okay, it's a fun game. The other part is, do you celebrate this and be like, I'm not saying what's on the card, but I'm saying this happened last week and I learned that insert whatever here, right? So you can even in the group focus on the learning from it of they don't have to necessarily share their screw up. It's great if they can, but what did I learn from this? What did I learn from things that didn't go well? It at least highlights the important takeaway, which is learning and, like improvement, and it avoids the psychologically more stressful side of things. So yeah, I think it could be very effective. Plus, realistically speaking, you're right. We have limited resources in residency.
Thank you for the topic. It was very interesting and certainly something that aligns with kind of what we do in our program. We have what we call mentor groups, and there's 6 faculty members. We have a small program, 18 residents in total, and each of the core faculty has 3 residents, 1 per year, and they stay in the same group for the entirety of their year. And we use that in several ways. It's a well-being mentor group as well, where we have a small cadre that can rely on each other and reach out and use a support system, with a faculty member being the lead. But then we also do small breakout sessions during our conference where each mentor group breaks out and we have a learning objective for that time period as well. But then finally, as it relates to this, I think most specifically is that we use that as a way to create our ILPs, and we try to iterate that every quarter. Now, certainly there's a group discussion, but because of what you talked about, the sensitivity of some of the more challenging learners, the mentor works with that individual as well, separate from their mentor group. So that allows us the collaborative effort of having a 3rd year, 2nd year, and a 1st year working together, and learning from each other's learning styles. But then it also allows for a safer space for a more problem learner. And then every quarter, there's a report that's generated from each individual resident's ILP that gets transmitted to our CCC program, our CCC meeting twice a year. So we have 2 reports every 6 months for each resident.
That's a really nice model that I applaud you for developing. I am very curious about the CCC report. What does that look like? Is this just self-report on progress towards goals and ability to execute their ILP?
So we have a whole ILP curriculum that begins with a learner assessment of their abilities and their objectives, and then that gets compared with the faculty member. There's probably 20 different, it could be more depending on the learner, items, both EQ and IQ, that the learner rates themselves, and then the faculty member rates themselves as well. And so that's the first step, and then there's several goal setting steps therein. So then the final report is what the listing of the goals, and then whether the goals were met and any challenges that arose in that goal setting, whether it's resources or learner wasn't able to complete it, whatever it may be, and that gets reported, and the mentor, the core faculty member, gives a reporting of that, and there's a form that I review as the program director, and then when I meet with each of the residents, we go over that as well.
No, that sounds like a tremendous resource for the residents as well and just what we were talking about with this. We know people are terrible at self-assessment, myself included, all of us included. And if we don't respect these self-regulated learning skills as learnable skills and nurture them just as we would airway management or difficult conversations or team leadership, we have probably done people a disservice. So I will second what Dan just put in the chat. I would love to see a presentation on this at court and see more details of your personal work. So as a shameless plug to help the next AA committee, I'm thinking the deadlines are probably going to be open for submissions are going to be opening up in the next couple of weeks. So I'd love to see more of that.
I just keep my mouth shut next time.
I was going to say, I was going to jump up
no
and
good
defend you
deed
from,
goes unpunished.
yeah, I don't want you to get bullied by these board members, but honestly, I agree with them. It's a great curriculum to present. I'm going to ask this because I think I know the answer. Are any of the faculty who are the leaders of this in residency leadership?
They're all core faculty members.
But are they PD, APD, people who
well,
are in charge of making summative decisions?
Yeah, myself and the APD are both core faculty members, and we're both we have our own mentor groups.
That's where it really gets interesting as to what people are really willing to talk about. I think there's probably two different, there's lots of buckets of this, but I would say this, and you would know best because you've been living in this and convert, like, furthermore, it'd be great to hear how this would come out in a talk at court to really hear the nitty gritty. For the people who are like, I want to be a toxicologist, right? That's a forward-thinking goal. It's not an ego-threatening goal. They could be an intern and say that. It's easy to put that on a record and say, I'm going to work towards doing that. They would love to share that with you as a program director. But the person who's like, I don't know if I'm an emergency physician, or I don't know if I like this, right? That's probably a lot harder with their leadership. So to the people who are struggling in that sense and figuring out their place, and that's maybe a little bit too extreme an example, but the idea of I screwed up. I did something where a patient really got hurt, but nobody ever found out about it. There's all these subtleties where I can imagine the lines of boss, assessor, summative assessment, control of resources, and my, counselor I can rely on gets tough. But again, all the more reason I'd love to hear about is like, how do you guys navigate these things in your program?
So our program is so small. There's six core faculty members. There's 18 residents. It's a fairly we create an environment of safety. At least we communicate that. We hope that is received well. I suspect it is. And your example of I don't know that I can be an emergency doc has come up with one of our very struggling learners, and it's really an all hands on deck situation. It's not my particular mentee, but I'm the program director. But it is an all hands on deck situation where in this particular case, the mentor is most intimately involved, but it gets transmitted through every core faculty member and actually every non-core faculty member as well, so that everyone is aware. And we just deal with it openly and honestly. But I understand your main point is program leadership can sometimes be an up here sort of situation that the resident isn't comfortable with. The one way that I, as program director, try to mentor that and role model that is I share all of my mistakes in an open forum during conference. And I tell them that, listen, I'm not proud of what I did, but if I expect you to take ownership of your failures, I have to role model that so that you're comfortable. Because if I'm comfortable being vulnerable to the group of 20-some people, then I would hope you would be vulnerable with a one-on-one situation as well. And that's the best that I can do in that situation, I believe.
And that really highlights the real world aspects that we have in constraints of resources in GME, right? There are many programs that are the size that you describe, or even larger programs, but it's still the scale as a problem. But what you did is you addressed the culture, right? You set the culture and the role modeling. God, after my years of doing this in GME, the more it came to my mind that the simplest rule for a successful residency program is faculty who are effective role models. Like, everything else falls into place. Like, if they just show you the right thing to do and act the right way, all the other things they're going to start picking up on. And so for you guys, being able to then realize that there may be these conflicts of interest, at least on paper, to demonstrate that, I think will win a lot. And I think, again, I'll reiterate, it should absolutely be submitted to something for CORD. That'd be a great thing for people to learn from.
Thank you.
I thought you weren't going to bully them.
I'm not a board member. I'm praising.
Thank you. Thank you.
Any other questions we can answer? Okay. Well, thank you all on behalf of Laura, Mike, and Linda, who weren't able to make it. We love being able to talk about this topic. We're also available if you want to reach out to us directly. We're happy to, talk about this, share any insights, share any of the materials. Hopefully you were able to get the QR codes from the presentation. But otherwise, thank you for your time and your attention.
Great. Thanks.
Thank you very much.
Thanks for the presentation. Appreciate your time.
You're welcome, guys. Bye-bye.